Topical human immunoglobulin as adjunct therapy in dry eye disease. Have no financial interests. The background work for this study is based on the fact that the cellular processes in the ocular surface, which are involved in the pathology of dry eye disease, have now been attributed to the presence of anti-citrullinated autoantibodies on the ocular surface, which increase the phenomenon of netosis, which is probably contributory to the refractory dry eye disease, which is present in these cases which do not respond to conventional dry eye therapy here. Review of literature points to the presence of netosis, which contributes to refractory dry eye disease and has been found to be responding to targeted dry eye therapy in such cases. Paucity of literature on the response of chronic dry eye disease to ocular surface human immunoglobulin therapy was a lacunae in literature which we wanted to evaluate, and the rationale for the study is that chronic ocular surface inflammation remains refractory to even topical immunomodulators like steroids, cyclosporin, and tacrolimus, and hence we look at targeted therapy in dry eye disease to increase the success rate in the management of these cases. The aim of this study was to evaluate the role of topical human immunoglobulin IgG eye drops 4 milligrams per ml as adjunct therapy in the eyes with moderate to severe dry eye disease. This is a prospective longitudinal interventional study done at our center during the period ranging from April 21 to July 22. The sample size comprised of chronic dry eye disease patients of moderate to dry eye severity with a minimum of 30 eyes as cases and 30 eyes as controls evaluated over a period of 6 months. The inclusion and exclusion criteria are as described in this here. The study commenced after obtaining Institute Ethics clearance, and CTRI registration was also obtained. Informed consent was taken from all study participants here. The flowchart of our study is as depicted. We looked at a minimum of 60 patients, 30 cases, and 30 controls with moderate to severe dry eye disease evaluated for ocular surface evaluation tests as the OSDI scores, the TBUT, the Schirmer's, hyperemia scores, the corneal and conjunctival staining scores were evaluated. We also developed a treatment grading score to give an objective score to treatment improvement when we used ocular surface immunoglobulin therapy. Topical immunoglobulin IgG drops was reconstituted from the commercially available intravenous IgG formulations here. Statistical analysis and appropriate tests was applied to our data here. Demographic detail analysis shows that the cases and controls group was an age and gender matched group here. And looking at all the study parameters of ocular surface evaluation, namely the DUCE2 scores, the OSDI, Schirmer, staining scores, and hyperemia scores, all showed a statistically significant improvement over the period of study evaluated at 3 months and 6 months vis-a-vis that seen in the controls of our patients here. These are all box whiskers plots depicting the distribution of the study characteristics over the study period time of all the study parameters which are being evaluated here, and all these go on to show a statistically significant improvement in the study parameters over the period of time here. These are certain representative photographs of the study participants showing improvement in their treatment when we used IVIG as an adjunct therapy in these cases here. Again, evaluating the change in treatment parameters, looking at the change in steroid dependency over the follow-up period, looking at the change in the frequency of application of lubricants over the period, all showed statistically significant improvements during the course of the study in our study subjects here. This table also shows the statistical significant importance both at 3 and 6 months vis-a-vis the comparison to our control group. Evaluating change in the median change also showed a good improvement in these cases here. So to discuss our study is there is a good improvement on ocular surface evaluation parameters over adjunct therapy on ocular surface immunoglobulin therapy. But what we did find, a minimum of 3 months therapy is required to achieve and to see an improvement in all the study parameters here. No correlation between the study severity and the steroid dependency in these patients here. Success rate determined based on our data showed an improvement in ocular surface evaluation in 75% of our cases. Treatment scores improved in again 74.9%, and the symptom evaluation OSDI improvement was seen again in 75% of our cases here. 4 cases we did have concerns. One was an ALL patient who expired due to systemic complications. One was a myelodysplastic syndrome patient who developed an anterior uveitis, which was not related to the therapy here. One patient of ALL had poor compliance and developed progressive cicatrizing conjunctivitis, and one AML patient developed microbial keratitis, not related to the medication because of poor follow-up here. Conclusion: adjunct therapy with topical ocular surface immunoglobulin IgG therapy has a significant role in moderate and severe chronic dry eye disease compared to conventional therapy in terms of improvement in symptomatology and reducing disease severity and ocular surface staining scores here. Limitation: a larger sample size would perhaps further enhance our result accuracies, and again a randomized study would probably also give us a better understanding here. Recommendations is that ocular surface immunoglobulin therapy can be considered as an adjunct therapy to reduce chronic refractory inflammation on these cases, on dry eye disease cases. These are my reference. I would like to acknowledge the contribution of all the co-investigators in this particular study here. Thank you for your patient listening.
Yeah, you can ask.
Very nice presentation. You have taken all very important points like OSDI scoring and all the different standings, but have you taken any inflammatory parameters like MMP9 or even the osmolarity in those dry eye patients?
So that would be one of the limitations here. But again, when you're looking at evaluating inflammatory mediator scores, the limiting factors is that a study sample of 30 cases is not going to be enough, because what you're looking at is nano ml of inflammatory mediators, and your study sample needs to be really large and huge if you're going to look at statistical significance. Again, all studies show that looking at inflammatory mediators is largely non-specific, because you cannot pinpoint a particular biomarker as an inflammatory mediator which will show improvement when you're giving a therapy.
Thank you.